Postpartum hemorrhage is a time-critical emergency and the leading cause of obstetrical-related maternal death. Immediate postpartum hemorrhage is significant ongoing bleeding after delivery, defined as loss of more than 1 liter of blood up to 24 hours after delivery. Delayed or secondary postpartum hemorrhage is excessive bleeding from 24 hours after delivery up to 12 weeks postpartum. The causes of delayed hemorrhage may be different than the causes of immediate postpartum hemorrhage, but the initial management approaches are similar. As we are generally poor at estimating blood loss, postpartum hemorrhage should be suspected when there is a significant change in maternal vital signs indicative of early or advanced hemorrhagic shock, including the development of tachycardia or a drop in the blood pressure. The shock index is a particularly useful metric to detect hemorrhagic shock, and a shock index greater than 0.9 is highly concerning for hemorrhagic shock in a bleeding postpartum patient. On shorthand, generally, if the heart rate is greater than the systolic blood pressure, we need to suspect some trouble. Conceptually, it is useful to think of a patient with postpartum hemorrhage as a trauma patient, and that is because the priorities of care for both of these patients, often with hemorrhagic shock, are the same. First, to slow or stop the bleed. Second, initiate rapid transport to the closest and most appropriate facility, in this case, one with access to both blood products and an on-call obstetrician. And the third is hospital pre-notification so that the needed resources can be ready as quickly as possible following patient arrival. Tone, which refers to uterine atony, or the failure of the uterus to contract down and decrease bleeding, is the most common cause of postpartum hemorrhage. Risk factors include grand multiparity, defined as greater than or equal to 5 vaginal deliveries at greater than 20 weeks gestation, or a twin or multiple pregnancy. This makes sense. The more the uterus has been stretched out, the less likely it is to contract down quickly and efficiently. The initial management of uterine atony is vigorous fundal massage. Because it is the most common cause of postpartum hemorrhage, fundal massage is the first line of action in response to postpartum hemorrhage in conjunction with initiation of rapid transport. In some EMS systems, ALS-level clinicians are also able to administer oxytocin to aid in uterine contraction and TXA to decrease hemorrhage, or IV fluid or blood administration to treat shock. The second cause of postpartum hemorrhage that is amenable to prehospital intervention is trauma, which refers to lacerations as a result of delivery. If lacerations are present in the external vaginal area, which is unlikely in delayed postpartum hemorrhage, apply direct pressure to the perineum with sterile dressings. The third cause of postpartum hemorrhage is retained products of conception or components of the placenta. Normally, after the placenta is delivered, this prompts the uterus to clamp down, which stems the blood flow to the area. When a piece of the placenta does not detach, this prevents this from happening and leads to continued hemorrhage. Of note, retained placenta can lead to delayed hemorrhage as well if it is not detected immediately after delivery. Retained placenta generally requires manual evacuation by an obstetrician to stop the hemorrhage. However, pre-hospital fundal massage is still indicated when transporting the patient to definitive care. The final cause is thrombin, which is a coagulopathy secondary either to inherited disorders such as von Willebrand's disease or the use of anticoagulants. Once again, these generally require in-hospital intervention to reverse, or ALS interventions such as pre-hospital transfusion of fluids and blood. Again, of the 4 T's, the most amenable to pre-hospital intervention are tone and trauma. Our priorities of care remain to decrease bleeding, first by vigorous fundal massage or holding pressure on visible wounds, and importantly, the initiation of rapid transport to the closest and most appropriate facility.